as this is the second webinar that focus on the special issue and from this journal, which is best practice in clinical and research, obstetrics and gynecology. And the journal a few months ago decided to have a special issue on twins and multiple pregnancy. In fact, we have 21 articles, and this special issue was published last month. And as an effort to promote the fantastic articles that were published in this special issue, Elsevier have supported, Elsevier as a publisher, have actually supported us to have these webinars to highlight the content and recommendations from the articles that were published in this special issue. We're doing it as part of this series of webinars, which is a twin and multiple pregnancy webinars that we started back in 2020. And that was webinars organized by the Twin Trust Center for Research and Clinical Excellence, which is funded by the Twin Trust in the UK. Twin Trust is the UK largest charity for twin and multiple pregnancy. And the center is based at St. George's Hospital, where I practice. So we started that back in 2020, and the webinars have been successful. So we carried on. So in 2022, we've been doing it monthly. And as I said, we dedicated the webinar last month and the webinar this month for this special issue. I think there will be a third webinar to also cover the special issue, which will be scheduled in January 2023. We have 4 topics today. The last one, we had 6 topics. We had fantastic webinar. I really enjoyed it. It was fantastic speakers, really good discussion, but the webinar lasted for 3 hours. And certainly the feedback was the fact that 3 hours of fantastic science on Sunday maybe is a bit too much, it was a bit too long. So certainly based on the feedback from people, they said, okay, we'll want to have 4 topics so that we maximum have 2 hours. And we are competing with the final of the World Cup football. So for sure we have to finish, because otherwise we're not going to have anybody in a webinar, including the speakers, if one watches the football. So the idea is that we have these 4 topics, each one with roughly about 15 minutes, followed by a discussion. And really people really value the discussion, the questions. I personally love your comments and discussion and interaction with the speakers who are experts in their area. So I think it's really good, fantastic opportunity to gain from their expertise, both clinically and academically. Common questions is webinar is recorded. Yes, it is recorded, and you would have had sort of this message to say the webinar is recorded, so that seeks your consent by saying yes, it's okay to be recorded. If you don't want to have your face or name, you are welcome to switch off your video. We mute everyone in the webinar to avoid any interference or any also respect to the speaker, so that it doesn't interfere with their talks and the discussion. But we communicate with you through the chat. So please, if you have any comment or any question, please put them in the chat. I usually do my best to go through all of them before we finish the webinar. Of course, if we have a really good discussion and people want to actually have the discussion verbally, and we're happy to unmute you, and then you can join the discussion with the speaker. Certificates, yes, you do have certificates if you have registered, and certainly the team behind the scenes. I don't do that on my own. So I've got Sumriti, you've got Jamila, you've got Nashwa, who are doing all the coordination behind the scenes. So they will actually send the certificates. I know it's important for CBDs and for your professional development. The other thing is this recording is usually available on the Twin Trust website, and also Elsevier. They've decided already that they will edit these webinars, and for each of the speakers, we will have this recording linked to your article on the website, which again, for the speaker, it's a really good opportunity to publicize your article, the work that you've done, and have more visibility, more downloads, and more readers. And for people that actually have access to the speaker actually summarizing their article in a video or recording, I think it's a really good opportunity for you. So that's the plan for the recording of these webinars. Okay, I think I spoke enough. I think I'm gonna stop here and maybe welcome the 4 speakers today, and you can see their the topics and their name there. We're gonna start with Professor Jung, who's gonna talk to us on determining chorionicity and amnionicity. The pitfalls is probably one of the most important topics in twins and multiple pregnancies, is to how to get the chorionicity right. So really important topic, and thank you so much for joining us. I know it's you're in the evening, so it's really kind of you to join us on Sunday evening. Yeah. And that will be followed by Lisbeth Louis. Lisbeth doesn't need introduction. Lisbeth is a professor of fetal medicine. She leads the twin service in Leuven in Belgium, and she is very well known for her work on the monochorionic placentas. I do remember when I was a very young researcher listening to your talk, Lisbeth, and these beautiful pictures of the placenta. So she's going to talk to us on what fetal medicine specialists should know about monochorionic placenta, and followed by Professor Anthony Johnson, who is again lead fetal medicine and fetal therapy expert in Houston, in the United States. He's going to talk to us on twin reversed arterial perfusion, the timing of intervention. And then after that, Enrico Lopriori, he will be the last speaker today. And Enrico is a neonatologist, so he's a professor of neonatology, and he leads a neonatal unit in Leiden, in the Netherlands. So the next speaker on the program today is Professor Anthony Johnson from Houston, from the United States, and he's going to talk to us on TRAP, or twin reversed arterial perfusion. So, Tony, would you be able to share the slides, please?
Okay, can you see them?
Yes, perfect.
Okay. Let's see if I can get them up to what I need now. So, good morning, everyone, or good afternoon, wherever you are. We'll hopefully be done in time for the World Cup. And actually, thank you, Asma. This is a talk really Elizabeth should be giving, so I'm kind of humbled to be here in her presence with this one. Talking about the timing of when we should be intervening, and timing here in the context of things is really an assessment of the fetus, or the pump twin, and also just the interventions, if you will. Just a disclosure, I'm one of the editors of Fetal Therapy. That and $25 will get me a cup of coffee somewhere. Okay. Talking about as far as for TRAP and looking at it and the incidence of the disease, we're looking at something around 1% of monochorionic twins, roughly 1 in 3,500 pregnancies, perinatal mortality somewhere between 35 and 55% due to pump twin demise, high output failure, severe poly. Recent work suggests, though, see if I can get there. Recent work suggests, though, that actually the incidence may be higher, looking at what we see in the first trimester and the first trimester loss rates. That the incidence may actually be as high as 1 in 9,500 pregnancies, and that we do see a significant loss rate in the pump twin prior to 18 weeks from some of the work that Dr. Lewis previously published, and we'll talk about that a little bit later in the talk. So what we're going to think about is, perinatal management, the time of intervention, risk thresholds. What's the risk of observation, and what are those factors that you need to look at, trying to detect high output failure, a severe polyhydramnios and preterm delivery, and trying to prevent this fetal demise by waiting. Versus the intervention, it's not benign. There's procedure-related loss, there's iatrogenic premature rupture of membranes, preterm delivery, there's maternal complication. The one thing about fetal intervention, it's a relatively boutique operation, so the instrumentation is somewhat limited in the context of things, and also at gestational age. What do we know about the various gestational ages as far as the intervention? Now, looking at the morphology of the classification from actually 1960, different parameters here, but in looking at this and looking at the long-term development, the one that seems to have the greatest risk of advance is the more advanced developed acardiac twin, where the head and the body and extremities are present. This seems to put more of a threshold on the pump twin for developing advanced disease. So anatomically looking at and when you make your first diagnosis, trying to determine what type of an acardiac can be beneficial in helping you understand where risk might be involved. This is a case from some time ago that we had where we suspected a vanishing twin in the first trimester, and looking at the embryo, no heartbeat was seen. And the physician actually elected to continue. Unfortunately, they didn't think to put on color Doppler to see actually that there was some flow here to this. In that particular case, we got a phone call about 8 weeks later where they noted the vanishing twin actually had increased in size. This is the cranium. This is the edema that we're seeing in this case. Here you have the pump twin up against the acardiac twin. So massive increase in size of this acardiac twin, causing significant uterine distension, polyhydramnios, and eventual preterm delivery, despite our attempts to occlude this with bipolar. Well, that sort of brings us to the Moore paper from 1990, which is the first paper talking about the acardiac mass. And looking at this, looking at the twin weight ratio, noting that in this paper, that if you had a twin weight ratio greater than 70%, that you had a significant increased risk for preterm delivery, polyhydramnios, congestive heart failure. So that even actually looking as high or taking that down to 50%, there's some data suggesting that, again, this is a predictor that the mass of the acardiac can help you determine what risk there might be to the pump twin. The Moore paper, though, is actually based on postnatal measurements, not prenatal measurements. So how well does it extrapolate back to the fetal estimated weight, and the acardiac is still really being evaluated. But there's been at least one report where they looked at the acardiac mass. This is out of UCSF, and there was actually overall approximately 76 trapped cases. And when they sort of whittle it down to the group less than 50% and looked at observed versus intervention, in the observed group, there were 11 cases with the acardiac mass had an estimated weight of roughly 50% of the pump twin. Now, in that group 3 cases, actually at the time of arrival to the center, there was no flow to the acardiac mass. So if you exclude those, there was one loss, 7 of 8. There was one loss in the observation group, as opposed to the interventional group, where the 100% of survivors. Note, though, that there was a relatively significant difference in the acardiac mass in the observed group versus the interventional group. So how well this pertains in the context of things, and also the observed group did deliver a little bit earlier than the interventional group, but at least gave us some information that size alone, if that's what you're looking at, can help you better understand who can be observed versus intervene. One thing, note, this particular report, none of the pump twins in this less than 50% group had 50% weight had hydrops, but there was no additional data on the pump status as far as for Doppler studies and fluid volumes, et cetera. Now, a much earlier report talked about some other parameters, small study, relatively only 9 cases, but suggested that looking at the umbilical artery, the pulsatility index of the pump of the acardiac to the pump twin, showing a reduction in pulsatility index may be a predictor. Shortening, showing an increase in the shortening fraction of the left ventricle may be a predictor, but most importantly, coming along also was the acardiac mass increasing in size. So size clearly does play a role in the advancement of compromise to the pump twin in the cardiac. Other parameters that are looked at: cardiomegaly, increased cardiac output, looking for tricuspid regurgitation. Doppler blood flows can provide information. Ductus venosus with absent or reverse flow in the A wave, a pulsatile umbilical vein, increased pulsatility index, as I just said a second ago, in the pump twin, clearly polyhydramnios, hydrops. Monoamnionicity also is a risk factor in the pump twin as far as your outcomes. Now, moving on, there's been a suggestion as far as incorporating a classification by Wong et al., where again they were looking at size. Okay, again using a ratio of less than 50%. In the absence of compromise, in this risk strategy, they suggested that repeating testing every 2 weeks, checking again if no treatment, just continue if there's increasing size, advance. Where in a 1B, there was a presence, they would increase the frequency, and then again, weight in the stage 2, type 2, A and B, where you've got increasing mass of the acardiac. In the absence of compromise, they would move towards therapy, but not emergent, whereas if there was signs of compromise, they would suggest that you do an emergent intervention. Pump compromise in this particular study was polyhydramnios, cardiomegaly, pericardial effusion, tricuspid regurgitation, abnormal Dopplers, as I previously stated. I'm aware of one paper that's actually looked at this classification and utilization of management out of China. A small study of roughly 22 cases looking at type 1A observation. Survival rate was 100%, only 4 cases obviously, but still a relatively good gestational age of delivery. Whereas in the 2A, observation had a 50% loss rate as opposed to intervention with radiofrequency ablation, had a 70% survival rate and also delivered a little bit later. In the type 2B, where you had advanced disease, neither one of the pregnancies ended up with surviving babies. So again, if you're going to observe, here's some information that might help us in the context of strategizing as to which case should be observed and which case should intervene on. Small numbers though. More recently, also talking about trying to predict the risk of as far as excessive cardiac output from Van Rammet, looking at the relationship between the umbilical vein diameter of the pump to the cardiac. Here, looking at this ratio such that a value where we see the ratios below 2, that there's predictive of compromise in the pump twin in some 17 cases where we see that the pump twin was decompensation, was demised, or there was an emergent fetal therapy needed or delivery, versus those where we had uncomplicated cases staying above. So again, possibly another predictor to help us assess and evaluate the outcome. And the advantage of this particular assessment is it does take us into the first trimester to look and see a way of predicting outcome in the pump twin. Now, all that said, looking at observation versus intervention, this systematic review said, well, and looking at the therapies, and again, these are predominantly second trimester therapies, that observation really probably is not the thing to do, that intervention is probably the better way to go with the overall survival rate, showing that there's clearly an increased benefit of intervention. And that increased benefit definitely increases when you're looking at poor prognostic indicators when you add those into play. Adding hydrops, polyhydramnios, abnormal Dopplers, increasing size of the mass, and again, monoimmunicity. So waiting in the second trimester when you're is probably not to the patient's best advantage with regard to outcome. Now, what do you do? What procedures? Well, really, when you look at the numbers, probably drop down to these 4 procedures are what most often done. And cord laser coagulation, bipolar, and RFA are predominantly second trimester procedures, whereas infrafetal laser coagulation is one that can be done as early as the first trimester, and we'll talk a little bit more about that later. Overall outcomes, you're looking somewhere around 75 to 80% survival rates with these particular procedures. So looking at them, it's really operator dependent. These 4, what works best in your hands, if you will. Now, as far as for bipolar, one of the big disadvantages about the bipolar is the size of the port. You're looking at a relatively 3mm device coming through. Targeted though in grasping, this is done particularly in a monoamniotic situation where you're going to incise the cord, but just again showing occlusion, multiple burns, if you will, to occlude because of the coiling of the cord. We'll proceed to twice. Now, when you go back and you look at some of the data as far as you're trying to figure out for TRAP specifically, part of the problem is when these reports are done, TRAP is really part of the procedure. So it could be discordant anomalies, twin-twin transfusion syndrome. This is looking at bipolars, where you're seeing that there's a low percentage, if you will, overall of TRAP cases in this. Survival rates here with TRAP specific varied anywhere from 40% to upwards of 90% with the use of a bipolar cord coagulation in the second trimester. If you're looking at interstitial ablation using radiofrequency ablation needle or microwave, I'm not going to address microwave, so there's very few reports on that. But if you're looking at RFA, that's probably the more predominant device used in this particular disorder for TRAP. Again, the same situation though. RFA is mixed in, TRAP is mixed in with other procedures, twin-twin and discordant anomalies, but more often TRAP alone. Survival rates here though with RFA are reported anywhere from 75% up to 90% in the TRAP, suggesting this may be a better particular procedure, at least in the second trimester and moving forward. Now, this report from Rossi et al. In this systemic review suggested, well, really, we probably shouldn't be doing anything before 18 weeks. But again, it was very heavily related to bipolar, if you will, versus the other interventions. But it then did suggest that earlier procedures had a greater risk as far as for pump loss as opposed to the later procedures. And when you separate it out by diagnosis, TRAP versus TTS versus severe malformations, even in the TRAP grouping, again, that the loss rate appeared to be higher in this cohort when procedures are done prior to 18 weeks versus after. Now, part of the problem, again, as I said a second ago, has to do with the device. If you look at RFA versus bipolar, this is some work from Julie Moldenhauer for the NAFNet experience, very heavily weighted towards RFA, if you will, some 300 cases as opposed to less than 30 of the bipolar. But there was a significant difference in the incidence of premature rupture of membranes and also maternal complications using bipolar versus RFA. So the ability to move forward or earlier in gestation with bipolar is not as likely due to the size of the device. And the same would hold true as far as fetoscopic work. While there are some reports looking at fetoscopic directed laser prior to 18 weeks, when you're getting much below 16 weeks, you're looking at a relatively large device. My slide stopped. Here we go. So let's move this forward to interstitial laser ablation. A little bit easier, smaller needle-guided procedure, 17-gauge needle using YAG or diode lasers, 400 to 600 microns, watts of anywhere from 10 to 40 watts, using 3 to 5 second burst. Relatively straightforward procedure for maternal fetal medicine specialists. Is an eye-hand coordination situation. Looking at it, it's ultrasound guided, targeting the device coming into the fetal abdomen or the cardiac abdomen, if you will. Targeting arm once in place, using here an 18-gauge diamond tip needle. We'll advance the fiber a little bit beyond the tip, marking the fiber with stereostrips so you know where you're placed. And it'll be a 3 to 5 second burn. Let's see if I can just advance this. And what you will find is you get this hyperechoic thermal damage. And we'll repeat that on at least two bursts to confirm that we have occlusion. This is actually from Osmo Center, looking at St. George's, looking at some 56 odd cases of TRAP under interstitial ablation. And you can see as far as for that, the long-term outcome for the pump survival rate, roughly 82%, with preterm delivery, 20%, starting as early here as roughly 12 weeks with this interstitial approach. Looking at this going a little further, when you separate this out less than 16 weeks versus greater than 16 weeks, what we found, what was reported actually, was that the overall outcome was better for the earlier procedures versus the later in regards to IUFD and preterm delivery, suggesting that in this particular device, we may be able to get earlier on in pregnancy. Part of this is driven by our previous speaker's report from 2010. Professor Louis, when she was at King's, talked to us about 26 cases actually of first trimester diagnosis of TRAP sequence, 2 of which terminated, but those that continued, a third ended up with fetal death prior to 16 weeks, arrest of flow in another 5, and then 46% of the cases persisted moving forward. So the overall survival rate, if you will, for the first trimester diagnosed TRAP case was 46%. Of the 3 cases, the 5 cases where there was arrest of flow in the acardic, 3 of the pump twins demise as well. Interventions after 16 weeks were successful, 90% survival rate with delivery greater than 32 weeks and 90%. So again, suggesting there's something going on in this first trimester that we need to be able to address, and with possibly an earlier intervention if we can pick up and get there and develop the appropriate therapy, if you will. Further on at King's, they sort of took that information and said, well, maybe we can go back here, and what do we see? Well, actually, with interventions performed early, we found that they reported that the gestational age of delivery actually was later, okay, significantly later when they performed earlier, although there wasn't a difference when they looked at 12 to 15 weeks versus 16 to 19 week intervention as far as survival rate. So advantageous, if you will, minimizing or reducing prematurity by going earlier. Very few cases, though, here in this initial report. Subsequent reports, again, still small numbers, 24 cases here between the two studies, and a significant difference as far as in the survival rates, if you will, for these first trimester cases, roughly 60% versus 90% survival rate, although delivery of survivors was actually quite nice at term overall. No premature rupture membranes rate was reported in one center and none reported at all, just no report of it in the second from Hamburg. This leads us to the present trial, the TRAPPIST trial, interventional trial looking at randomization between early versus late for TRAP sequence, open label. Professor Louis is the PI on this. This is a trial looking at a one-to-one randomization, early intervention for first trimester prenatal diagnosis of TRAP sequence and a monoclonic diamonic 20. Early intervention is 12 to 14 weeks. Late is 16 to 18 weeks. The sample size is based on an estimate for early intervention, a survival rate of 75% and late 50%. To date, we have approximately 54 patients enrolled in the trial. So with that, concluding that the loss rate with first trimester diagnosis of TRAP sequence could be anywhere from 60 to 85% overall. Conservative management with ultrasound surveillance may be reasonable in some cases. Risk for second trimester is pretty well established. I mean, hydramnios increase a cardiac mass, cardiac decompensation. There may be some information looking at umbilical vein diameter as a potential screening, and it can actually work as early as the first trimester, at least in this preliminary data. Still more work needs to be done here. Preliminary data suggests intervention less than 16 weeks is feasible and effective. Safety is as of yet unproven and should be regarded as experimental at this time. The RCT is needed to be completed to further evaluate the use of this intervention at 13 to 14 weeks versus 16 to 18 weeks. Thank you for your attention.
Brilliant. So very fantastic overview on the TRAP and also the prognostic features, the management options, and the timing, and the controversy about sort of the timing, which hopefully will be addressed in the TRAPPIST trial. So you're right. I think we have a really fantastic opportunity because you've got Lisbeth Louis here as well. So I'm sure you always contribute to the discussion, Lisbeth. But thank you so much, Tony. That was brilliant. Before I ask any questions or start the discussion, I think David has a question. So we had a case with TRAP. And at 18 weeks, we did the intrafetal laser with success, but after 4 days, the normal fetus died. So the bump twin died with edema and ascites. Unfortunately, what do you think? Why? That's not unusual.
Yeah. We had that happen once before, and actually it was with an RFA, so I can't speak to his interstitial, but where we applied the device, we applied 3 cycles, looked like we had an occlusion, came back actually 24 hours later, and we found now we had actually repatency, if you will, and the pump twin was passing, and we lost the pregnancy. We were able to recover the pregnancy though, and on autopsy we found that we had scored, but we had not totally occluded the umbilical vein. Okay, so what happened? And there's actually literature showing that, David, it'd be interesting to know how many cycles you went through with your interstitial laser, because again, if you're getting to multiple cycles, you're spasming, but you're not occluding. Okay, so that's the big frightening thing for me is if you're getting past that second cycle and you're still seeing flow, that's going to be a problem in the context of stuff. You want to shut it down. I mean, used to be a commercial here, Bob Vilas, mark twice, cut once. You want to be right on target with your device where you have to be to apply your energy.
Yeah. Yes, you're absolutely right. So, and I wonder whether, and I mean, the literature does support that intrafetal laser or radiofrequency ablation, they don't have the same control as a cord occlusion.
No, they don't. Like, I mean, the cord occlusion, you're on target, you're closing, you're sealing that. And, I mean, RFA it's forgiving, okay, and in a trap situation. But again, the way the tines work, it's a splater process. Whereas with interstitial, you're more of a targeted type of a situation. You're pinpointing where you're going. Whereas, and again, it's the heat energy between the RFA. I've not worked with the microwave, so I can only speak to what I've read. And we've gotten more comfortable with the interstitial, especially as we look into moving into the earlier cases. The RFA produces a very big burn, okay, in a very small target, and then you get into more tissue damage and more concern with that.
Yeah, absolutely. There's a question here from Mabruk, Dr. Mabruk. With the survival rate after intervention, what are the comorbidities and quality of life in those babies? So about sort of evidence of other morbidity outcomes or long-term neurodevelopmental impairment in the bump twin. Is there any evidence of that?
I'm not aware of, I mean, other than prematurity, I'm not aware of anything that suggests an increase in long-term, developmental problems in those fetuses. I am aware of some work talking about cutis aplasia in some of the thermal damage cases, but again, whether it's cause effect from the intervention, it's not completely clear. So I don't know, Liz, I'll let you jump in here.
Yeah, so it's an interesting question. So we miss data, and in the TRAPPIST trial, we're also collecting the long-term outcome because there's very few data. I know that when I think it's the publication 2010 for more cord occlusions that we observed quite a few children who had late cord occlusion for TRAP, who had developmental impairment, and from a pathophysiological point of view, there is some concern for delayed brain problems because of the deoxygenation, because of the vein-to-vein anastomosis that brings the deoxygenated blood back to the pump twin, and also these pump twins have brain sparing. So there's definitely concern with late intervention that these kids may be disadvantaged for more neurodevelopmental delay.
But do you think
that also
is there other cases that, let's say, was missed or diagnosed late, and already, let's say, by the time they were referred, the bump twin had polyhydranias and had cardiomegaly or maybe hydropic, and perhaps maybe already there was sort of some extent damage before you do intervention?
Yeah, it's possible. I mean, these were early cases where we didn't do routine MRI scans, but yeah, it's a weak argument in favor of early intervention and not wait until the third trimester when you already have advanced cardiac decompensation but the pathophysiology of the TRAP may causes a degree of deoxygenation in the pump twin, which may not be a good thing for its brain development.
Yeah, I mean, what about the prognostic features? So there's a number of papers that looked at the size of the TRAP mass in relation to the bump twin, the 50% cutoff. Is that something that you, and that question that goes to sort of Tony and Elizabeth, do you routinely use that in your practice?
No, honestly, we're very aggressive. I'll be quite frank. If we see increased growth, we're just going to go. If we've got the diagnosis, we see what's going on, it's continuing. We've gotten into trouble where they've waited, and you actually, as recently as 3 weeks ago, we had a patient came in. Actually, we were attempting to randomize to the trial. The patient was undecided. She came in, was seen, everything looked fine, and then we noted that, wait, this fetus now has an increasing heart rate, okay, had gone from a baseline of roughly 165 that was in the high 180s. Brought her back the next day, we were seeing signs already of ascites and stuff. No, so I think it's unpredictable. I think if you see increasing size, I'm not sure, we've played a little bit with the ratio of the umbilical vein. We have seen some of that as a potential, but not enough. The cases are so rare. So anything that says that there's any kind of a change, we're going to go after it and make the recommendation to move on it. I don't think there's any advantage in waiting, especially with the interventions what they are.
Yeah. Okay, so two questions. Certainly we had a case a few years ago where we did the intrafetal laser, and you achieve occlusion, so there's no blood flow on the Dopplers, and the next week things were okay, and then they follow up locally, and then she comes back because we do an MRI in these cases, and in the scan before the MRI, actually certainly there was some flow in the trap mass, and it was growing very slowly, but you can actually measure certainly a femur. So certainly the occlusion was not complete, and sort of we thought it was complete, but it wasn't complete, and the follow-up locally did not sort of look at the blood flow in the trap mass anymore. Because the bump twin was completely fine with normal Dopplers, normal amniotic fluid, we decided just to expectantly manage this case. We did not really want to interfere again. Would you do the same, or would you do something different?
There's no doubt going back in a second time is going to heighten your risk. Okay, you put a second hole in, the first one didn't heal, so your prom rate's going to go up, etc. I think it would be somebody we'd be anxious with. We would want the fetus, the pump, to show me something. If the pump was totally stable and nothing was going on, we would probably ride. But again, if there's increasing growth of that acardiac, it's going to be a problem. It's just a matter of when, and I would venture a guess most neonatologists, same as here in the US, high drops at 28, 29 weeks is not something they like to see in their NICU. So, if it's changing, if the flow dynamics, if we would look hard, if we found anything that suggested that this is leaning towards increasing compromise of the pump, we would go after it. I'm not as comfortable just in the context. I mean, obviously the interstitial laser is an 18 gauge needle. It's a relatively benign procedure. I'm just not as comfortable utilizing that when you get into advanced gestation above 18, 20 weeks. It's a lot of target you're trying to slow down. We would go probably either with an RFA or a bipolar. Even the RFA, one of the companies makes a 14 gauge. You could probably stop a whale with it. It's so big a needle. But again, the damage from that, I would probably go for a bipolar after 22 weeks on something like that, because you've got such a large vessel that you're trying to close, even with low flow. You want to be assured there if you're going back the second time.
Yeah, I mean, we wanted to have reclosity, and that she was already 28 such weeks. So and the bumps were completely normal MRI, normal everything. So we actually managed conservatively, and she had a very good outcome, and the bump twin was completely normal. She delivered, I think, about 35, 36 weeks. So I mean, it's not that clear cut. And my final question before we move on to Enrico Lopriori's talk is late referral or late diagnosis, let's say 22 weeks, anterior placenta, the bump, the trap mass have very little fluid, which often they have very little fluid, very short umbilical cord. What technique would you use?
With an anterior placenta?
Yeah.
How about 22 weeks?
Yeah. Very short umbilical cord.
Well, if it's a short cord and you can't access, we would probably go with an RFA. Just go straight down to it. Would be the simplest thing to do, just because one, you wouldn't enter the pump sac, so you're minimizing risks of that. I mean, we do everything we can to avoid the pump sac, as in access. And anterior placenta is going to be to your favor in that regard. So that's how we would handle that.
And if it was posterior placenta?
Well, you got to do what you got to do to get there. Okay. I mean, again, same situation. I've done them with a bipolar that way to get there, because again, access through, and that's no different than what I would do for a twin. So I counsel the same type of a risk, because it's a 3 millimeter port that we're coming in with the bipolar to grasp it. Again, it's gestational age. How big is the vessel I'm looking at? You're in your first case, you're talking about an anterior placenta. You're constricted by your access, and now you're going to be doing a lot of manipulating, trying to get there with a bipolar in that regard. An RFA, I think, would have a less risk of a complication and probably a good satisfaction. But on the other, if I've got to go down, if I'm going to make a single stick on it, I would probably go with a bipolar for the posterior at 22 weeks. That would probably be our approach here.
And what about sort of actually just going with a laser just like if you do in GTTS, you're going inside the sac of the pump twin and just target the anastomosis.
You know, I mean, I've done it a couple of times, but I'll be honest with you, the target's the cord, okay, in the context of stuff is what you're trying to stop, okay. For me, it's like just go to the cord, grab the cord, be done with it. You're using the same port, okay, and it's less placental, less membrane damage, okay, that if there is damage from laser, okay. So that's how we would handle it. That's my bias.
Okay, great, fantastic. Well, thank you so much. I think we had a really good discussion, really good practical messages there, and highlighting obviously the TRAPPIST trial. So that's fantastic. We'll move on. Thank you so much. I'd like to really huge thanks to to Enrico and the speakers. Fantastic webinar. I'm seeing all the messages in the chat box where people really have saying how fantastic the talks are and at the high standard level of the webinar. So that's huge. That's credit really to you guys, the speakers, and to your papers. And just maybe highlight that the Elsevier, the publisher, made all the articles in this special issue free to access and download, I think, for about 9 months. I'm not sure why 9 months, maybe because the pregnancy lasts for 9 months. I don't know why, but that was brilliant. That was great. And just to give you an idea, we had 327 people registered for this webinar. From my experience, about a third actually join live. A lot of people listen to the recording after the webinar. So just again to reiterate, the recording would be available both on the Twin Trust website, and Elsevier is editing these videos to have the relevant recording attached to the individual articles.